Hello. Hello. Yeah, good evening, Pankaj bhai.
Good evening, sir.
Good evening. Yeah. Now Bridges is just starting. He is
Yes.
the so as soon as he starts, then we will I think start. Doctor
Yeah.
Gite will join in another 5 minutes. Huh?
Okay.
And Hiren is traveling. He is going to Greece.
Oh, wonderful.
Yeah. So you are the main. Okay. Okay. Just wait for. Huh? Hello. Um. So today accounts Hassan, Soliraj, and Hamid. Four of you are answering, correct?
Yes, sir.
Yes, sir. Good evening, sir.
Good evening. Good evening. And you have got a tough examiner today, Dr. Pankaj Maheshwari, who has written many, even a chapter in Campbell. So, answer to the point, like he has taught you in last 3 or 4 clinics, to be very precise. Okay?
Yes, sir.
Okay, fine. Pankaj bhai, can we start?
Surely.
Yes, Brijesh.
The 82-year-old male came with a complaint of burning sensation while passing urine and lower abdominal pain since 2 to 3 days and fever since 2 days.
Yeah. So, Ekansh, these are the three main complaints. So, how you are going to go about? And Dr. Hudedar, please unmute yourself so you can be also part of our team.
Okay, sir. He's 82-year-old male. He has three chief complaints. He has burning micturition, and he has lower abdominal pain for 3 days, and he has fever for 2 days. Because he has fever, now I need to know the onset of and associated symptoms, and what is the Tmax, and diurnal variation of the fever associated with chills and rigors. And for the burning micturition, I need to also know, is there any other, is there a frequency increase, urinary frequency? Is there mm, other urinary complaints, and lower abdominal pain also he's complaining of, which so I would also ask about flank pain, and I would also rule out other systemic causes of fever.
Okay. Hussein, Soliraj, you want to add? Don't repeat the same thing. You want to add anything?
Any sir prior history of catheterizations or any similar complaint in past, sir?
Okay. Fine. Hamid, you are there?
Yes, sir.
So, Hamid, now you just finally you tell us you want to add anything or you want to stop here.
Uh, just want to know the associated history of lower urinary tract symptoms associated with the pain onset, duration, progression, associated features, and hematuria, and lithuria, pyuria, and dysuria. That's it.
Okay, Bridget, go ahead.
He was relatively asymptomatic when he first started developing the complaints. Increased frequency, overflow urgency, urgent continuous. Symptoms are insidious, gradually progressing, no specific aggravating or relieving factors. He also had straining while passing urine. He developed complaints of burning micturition and lower abdominal since 2 to 3 days. All increased in onset. Pain was initially mild, dull aching, but has increased in intensity since few days. He also has incomplete or voiding sensations and increased frequency associated with breathlessness and weight loss. Hello? Hello? Hello?
Yeah, Brijesh, you have been audible.
Okay.
Okay, so Hussain, where do we stand? What is your thinking going on at this time?
So, sir, apart from that, I would like to rule out the other issue also, whether associated with hematuria is there or not. Any past history of lithuria is there or not? Prior history of catheterizations or the similar thing, I would rule out. Apart from that, sir, I want to rule out any significant past and the personal history also, sir.
No. You see, the way we should be analyzing this patient is, Brijesh, go back to the first slide, please. So we have a 80-year-old man who is presented with 2 days history of features suggestive of lower tract infection. So there is burning in urine, lower abdominal pain and fever. So don't jump to past history at this time. First, let's first completely evaluate the lower tract symptoms, whether this is hello,
Audible, sir.
बीच में किसकी आवाज आ रही है? So we have a patient who is presented with 2-day history of Gaurang bhai,
हुदेदार
I
सर
think Anil bhai. Anil Hudedar.
Yes.
डॉक्टर
He is
उदयदार
echoing
शायद
coming.
आपके दो फोन चालू है क्या? दो
Yes.
yeah, better. So now a patient at 82 years coming with lower tract infection, first you should evaluate the other lower tract symptoms. So those have been given to you. Come to the next slide. Brajesh, move forward. So they have told us that the symptoms have started 2 years back. He had both storage and voiding symptoms. Okay. So 2 years history of storage and voiding symptoms now leading to lower tract infection. So what are the other things you want to know and how do you want to proceed further?
So, sir, as I'm suspecting, sir, it would be a changes of chronic cystitis or chronic prostatitis. Chronic urinary retention would be one of cause, sir. So based on that, I want to rule out the other issue also, sir. So whether it is associated with hematuria, prior history of catheterization is there or not. Then if it is associated with any stone disease, bladder outlet obstruction or associated with the stone disease, then I want to rule out associated lithuria is there or not, sir.
No. You spoke of chronic cystitis, chronic prostatitis, and chronic retention.
Right, sir.
How do you come to these three conclusions? There is history of only 2 days. Have they
देखो
told?
So, sir,
mix LUTS storage and voiding for 2 years and recently 2 days only history of suggestive of some dysuria or indirectly suggestive of UTI. तो ऐसे सिचुएशन में 82 ईयर ओल्ड मेल है तो क्या तुम्हारे दिमाग में आया है कि क्या हो गया होगा इसको?
So it would be, sir, bladder out.
Hussein, what they are asking you that when such a patient comes to your OPD, immediately what are the differential diagnoses that will come in your mind? This patient has got, correct, both the
Right.
symptoms, that is voiding as well as storage problems since last 2 years, and now since last 2 days he has got dysuria also. So what are the possibility that is coming in your mind? So what are the causes of lower intake symptoms? Basically, you tell us.
So, sir,
In
it would be
82-year-old male, what are the things you are expecting?
So it would be associated with, sir, bladder outlet obstruction,
Very
whether a
good.
benign or malignant cause associated with recent history of UTI, sir. So it would be one of cause. The similar thing may be associated with stricture urethra. There would be
No,
neurogenic
you
bladder.
said bladder outlet obstruction, so it may be because of some stricture, it can be
कुछ भी
because
बातें
of.
मत करते जाओ यार. 82 ईयर ओल्ड मेल में स्ट्रक्चर रहता कहाँ से आ गए?
So
See, again, the examiner will ask you this question.
So Hussein, you see, and this is for everybody to understand. The moment you use words like chronic prostatitis, chronic urinary retention, आपका केस यही छूट जाएगा and the examiner will start discussing how does chronic prostatitis present. Does chronic prostatitis present with 2-day history of fever? How many times have you seen chronic prostatitis in an 80-year-old gentleman? Okay, so please think before uttering any word. Hussein, again you are repeating the same mistake which you did last time. you do not need to give 10 differential diagnoses. So this is a 80-year-old gentleman with lower urinary tract symptoms with infection. My clinical judgment is bladder outlet obstruction related to, most likely related to prostate, which could be benign or malignant. इसके आगे बोलने को आपके पास कोई रीजन नहीं है. स्ट्रक्चर आप कैसे सस्पेक्ट करोगे? हाउ डज स्ट्रक्चर लीड टू अर्जेंसी एंड अर्ज इनकॉन्टिनेंस? A typical presentation of stricture will be normal frequency, poor flow. Okay, for stricture, the history is not very classical.
Sir, maybe associated with stricture with UTI or something.
But why do you want to talk about stricture?
Stricture क्यों हो गया
I
होगा
agree, sir.
इसमें? Why you are thinking this patient has got stricture? इसमें सिंपल पहला अगर बोलते थे कि भाई ब्लैडर आउटलेट ऑब्स्ट्रक्शन विथ यूटीआई, ब्लैडर आउटलेट ऑब्स्ट्रक्शन क्यों हो गया? बिनाइन एनलार्जमेंट ऑफ प्रोस्टेट, मैलिग्नेंट एनलार्जमेंट ऑफ प्रोस्टेट, आपने जो बोला था वो आ गया, उसके बाद में आएंगे. इतना बोल के रुक जाना. एग्जामिनर और कुछ पूछ रहा है तो वो उसके फिर हिसाब से आंसर देंगे, जैसा पूछ रहा है वो हिसाब से आंसर डिसाइड करेंगे.
Yes.
क्योंकि कैजुअल तुम्हारे पास ओपीडी में पेशेंट आया तो तुम खुद ही लिखेंगे कि बीईपी बोल के, लेकिन यहाँ क्यों नहीं बोल रहे पता नहीं.
So Hussein, as Dr.
Yes, sir.
Pankaj Maheshwari has made it very clear, correct? The question is that if this 82 years old male, if he has got stricture, he will present earlier at the younger age group or he will present at this age group?
Earlier, sir.
So someone has asked, can you say bladder outlet obstruction this place? Why cannot we say? Because this patient had a 2-year chronic history of storage as well as voiding symptoms. So yes, we can say it, na?
So again, remember that we need to get through the history very fast. So speak minimum and keep on trying to push examiner to the next step.
Exactly.
Okay, so if this question was asked to me, I would say 82-year-old gentleman with recent infection with a 2-year history of lower urinary tract symptoms. Clinically, I suspect bladder outlet obstruction related to BPH or cancer prostate. I would want to examine the patient. Okay, or I want other history if you want anything more.
Sir, why we are not putting differential of neurogenic bladder with raised PVR or chronic urinary retention at this stage?
Chronic
We have
urinary
not.
retention कैसे diagnose होता है? How do you diagnose? What is chronic urinary retention? चलिए, let's discuss CUR now.
So right, sir. But as we can elaborate the rest of the history, sir. So
देखो,
there will.
what is commonly found at this age with these symptoms?
So
अगर
one is
लिस्ट बनाना चाहते हो तो लंबा चलेगा. फिर उसको हिस्ट्री ऑफ इंटरवेंशन निकलेगा तो स्ट्रक्चर भी निकल सकता है. फिर इसको हिस्ट्री ऑफ पहले ये कोई ट्रॉमा, हिस्ट्री ऑफ फॉल है, पैराप्लेजिया है, एग्जामिनेशन के बाद तो उसको न्यूरोजेनिक ब्लैडर भी निकलेगा. कोई सीएनएस का कोई इश्यू निकला है तो वो कुछ भी निकल सकते हैं ना. लेकिन ये इतने सिम्टम के साथ कॉमनली क्या पकड़ना है, तो इतना ही पकड़ना है कि बीएपी विद बी हो या फिर सीए प्रोस्टेट विद बी हो विथ यूटीआई. अब जैसे हिस्ट्री आगे रिवॉल्व होते जाएंगे वैसा कुछ ना कुछ अगर मिला तो वो हिसाब से अपन डायग्नोसिस भी चेंज करेंगे.
And to clinically suspect chronic retention, what is the commonest presentation of chronic retention? Now tell me.
would be overflow incontinence, sir.
Obviously, फिर है क्या उसमें?
So do you have that history?
Right.
ठीक है. What do you want next?
Sir, any history of hematuria is there or not? Previous history of catheterization. Any history of weight loss or constitutional symptoms of malignancy?
Anyway, chali. Dr. Gite, what do you want to say on this?
यस सर।
हाँ जी,
नहीं, आगे चलते हैं ना, कुछ पूछना है
बिल्कुल।
क्या?
नहीं नहीं। हम्म,
Bridges, go ahead.
So IPSS score is mentioned in symptoms had a significant impact on daily life and very bothersome to the patient. There was no history of any hematuria, leuturia, no any previous instrumentation, catheterization, no nausea, vomiting, no edema or facial puffiness, no bony pains. There was mild weight loss.
Bridges, go ahead. Finish. Finish the history.
Okay. So he didn't have any comorbidities. He was vegetarian, bowel regular, bladder habits were altered as described because of the frequency urgency, sleep disturbed due to nocturia, non-smoker, non-alcoholic. Now it's clinical examination. Conscious, cooperative, well-oriented, pulse and everything was normal. Genital examination was also normal. Rectal examination revealed a grade 3 enlarged prostate, firm in consistency, smooth surface, medial sulcus palpable, and rectal mucosa mobile. No any bleeding on gloves.
Okay, Dr. Hamid,
ठीक है।
what is your clinical impression now? Who are the other students who are participating? Yes,
Yes,
Solaraj. What is your
Solai.
clinical impression? Tell me.
So, patient came with a history of mixed lower urinary tract symptoms with 2 to 3 days history of UTI. So, clinical diagnosis will be bladder outlet obstruction, more likely benign prostatic enlargement with supraduct UTI. Cystitis.
Fair. Anything else you want to know in clinical examination?
Sir, abdomen, like bladder palpable or not? We just have to see.
They have told bladder is not palpable.
Sir, on DRE, I want to know about the perianal sensations, the anal tone, and the bulbocavernous reflex.
So, do you have those details? So, let's presume them to be normal.
Any previous history of UTI? Any previous history of admissions for the same complaints? Any previous history of any medications is taking?
No.
देखो, एज फार एज द व्हेन नेगेटिव हिस्ट्री, जो भी तुम्हारे दिमाग में 10-5 डिफरेंशियल डायग्नोसिस आए थे, वो सबका 2-2 लाइन पूछना है। समझो, हिस्ट्री ऑफ ऑपरेशन, हिस्ट्री ऑफ इंस्ट्रूमेंटेशन, हिस्ट्री ऑफ कैथेटराइजेशन, हिस्ट्री ऑफ स्टोप पासेज ऑफ द स्टोन, हिस्ट्री ऑफ हेमेचुरिया। क्यों पूछ रहे हो, एग्जामिनर को पता चलना चाहिए। है तो अपना स्टोरी बना 3-4 हर एक का लिख के रखना। 6 प्रोस्टेट के ये 4 पूछूंगा मैं, ये स्ट्रक्चर के 2-3 पूछूंगा, क्रॉनिक रिटेंशन के पूछूंगा, न्यूरोजेनिक ब्लैडर की है, ट्रॉमा है, ऐसा एक उसका ये बना के ही रखना है। तो एग्जामिनर को पता चलता है कि ये 3 सिम्टम्स इसकी वजह से पूछ रहा है, ये 3 सिम्टम्स इसकी वजह से पूछ रहा है।
Yes, sir. Sir, I want to ask one question that what should we code the most common complaint of BPH? Like, is it the frequency or is it the hesitancy or is it incomplete wording, sir? I'm just confused in these three.
So, you see, there is nothing like most common symptoms. The most common bothersome symptom for patients is nocturia. Okay. Hesitancy usually suggests that probably it's a medial lobe enlargement. So, whenever patient complains of difficulty in starting void, especially when the bladder is overfull, clinically you may think of significant medial lobe enlargement. But otherwise, the commonest bothersome symptom is nocturia.
Okay.
Usually, storage symptoms are more bothersome than the voiding symptoms. Anything like frequency, urgency, urgent continence, nocturia. तो और सबसे इम्पोर्टेंट है कि अगर मैं ऑफिस वर्कर हूँ, मेरे बाजू में ही टॉयलेट है, मैं 5 के बजाय 10 बार जा रहा हूँ, तो मेरा वो आदत हो जाती है. And that may not be, but that should hamper your day-to-day activity. Then only it is called as bothersome symptom.
Okay.
Okay, so how do we proceed further now?
Sir, in this stage, how practical is it to ask about ejaculation or sexual history, sir?
80-year-old में अभी कौन से कंट्री में ये इम्पोर्टेंट है इतना?
That's why, sir, like, to be in paper.
इंडिया में तो नहीं थे, लेकिन और कोई दूसरे भी कंट्री में मुझे नहीं लगता कोई ये सेक्सुअल हिस्ट्री इतनी इम्पोर्टेंट रहेगी ये 0 ईयर में. क्योंकि अगर तुम सिचुएशन के हिसाब से नहीं पूछेंगे तो फिर वो क्या है कि एग्जामिनर का तुम्हारे ऊपर का ये जो कॉन्फिडेंस है वो लूज हो जाएंगे. नहीं, ही इज नॉट इन वेरी कीन इन टेकिंग द एग्जाम, गिविंग द एग्जाम, टेकिंग द हिस्ट्री. मुझे तो ऐसा ही लग रहा है ना. आप क्यों सेक्सुअल हिस्ट्री पूछेंगे भाई 80 साल के बूढ़े आदमी को? क्या करने वाला है?
Just for like to be in paper answer.
So, Soleraj, my suggestion will be that you should ask this history and keep that history with you and talk about it only if the examiner asks you.
Exactly.
Don't venture into this.
Okay, sir.
Okay. You see, this is, I will get tired saying this, that you have to get through history and clinical examination as early as possible. The moment you come to investigations and treatment, that is a field where you will be able to manage things much better than what you can manage differential diagnosis, history, why which symptoms happens. Let's get through that as early as possible.
Yes.
Do not utter any word which will put you in difficult situation.
Sure.
So keep this history with you. Only if examiner asks, आपने पूछा क्या? तो हाँ मैंने पूछा. बताया क्यों नहीं? बोलो he is 80 years, he is not sexually active, or whatever you get the history.
Yes, sir. Thank you.
ब्रिजेश, क्या हो गया? हाँ, yeah, Bridges is just joining. Meanwhile, if you can just ask other some questions, Pankaj Bhai.
Sir,
Someone has asked on the ये क्या बोलते हैं उसको chat कि sir, we will all examiner accept a single differential diagnosis at this stage. If you are confident in defending that single diagnosis, yes, that can be told. But in this patient, it is not a single diagnosis. ना bladder outlet obstruction is single. ये that is a common synonymous name है. लेकिन the pathology behind that bladder outlet obstruction, या number of causes आ सकते हैं ना. Secondary to समझो BEP है, secondary to shear prostate है, secondary to sometimes prostate with stone है, second with UTI है. ये सब चीजें आ जाती है ना. तो single diagnosis कहाँ बचा है?
Yeah, you are talking of a single pathology in a way.
So, Ekant, now you tell us what are the probabilities?
Yes, sir.
One is a bladder outlet obstruction. You are saying bladder outlet obstruction. Now patient has developed some infection also. But similar symptoms, what are the combinations? What are the combinations? You will not be surprised if it comes. Tell us.
Sir, this patient can have a bladder outlet obstruction secondary to benign prostatic enlargement with UTI. That is the first one. Second is bladder outlet obstruction secondary to malignant prostate enlargement, CA prostate, with UTI. Third is bladder outlet obstruction with prostate enlargement with some anatomical anomaly, which is causing recurrent UTI maybe. if he's having a recurrent UTI. Uh, and then
What anatomical anomaly are you thinking of, Ekach?
um, so he could have
Enlarged prostate or stricture or CA prostate is not anatomical, causing
uh,
obstruction.
like he could have because of bladder outlet obstruction, he will have that stigmata, he'll have trabeculations and all, but he could have a diverticulum. uh, if it's a large bladder diverticulum, that could be causing recurrent UTIs.
So, so tell then differential diagnosis, na?
So,
Yes.
so
So that can be
you are suspecting congenital diverticulum and presenting at 8-year-old with UTI. Because if pathology is prostate, it is enlarged prostate, and if it is causing the secondary diverticular formation, it is not a primary, then you already told now about the prostate. So, question is straightforward. What anatomical क्या बोलते हैं उसको problems consider कर रहे हैं आप ये एज पे? Because everything is secondary to the outlet obstruction. जो भी हो रहा है, ट्राइबेकुलेशंस, जैकुलेशंस, डाइवर्टिकुलेशंस, उसके बाद में थिक वॉल ब्लैडर, हाइड्रोटोनेफ्रोसिस, स्टोन फॉर्मेशन, एवरीथिंग इज सेकेंडरी. उसके लिए कारण है. तो आप भी सर ने वही बोले ना कि जो भी कुछ बोलना है ना, सोच के बोलना है.
so. Okay, so I am asking you again and again. For example, say you tell me what are the probabilities. So now you tell us everything. So as you are saying, there is a outlet obstruction, and because of that, there may be a diverticulum. Number one. Second thing is, if because of obstruction, there can be, what else it can be? As Dr. Gite said, there may be a stone formation.
डाइवर्टिकुलम क्लिनिकल डायग्नोसिस बहुत बार नहीं बनता है. क्यों?
And then,
क्या
if the
सिम्टम्स है
examiner is asking
डाइवर्टिकुलम
you,
के?
if the examiner is asking you, and if you have to answer, like, what are the other probabilities? So, it's like a stone formation, urinary tract infection. As you are saying, there may be a multiple diverticulum. What else it can be? There may be upper tract, uh, you know, hydronephrosis, hydrouresis. Fine. Bridges, go ahead.
So these are all complications of bladder outlet obstruction. Don't call it as an associated pathology.
Yes.
Sir, to show the investigations.
Let them ask, na. So,
Yeah.
Hussein, what are the investigations now you want?
Sir, I would like to ask for a complete blood count, renal function test, ultrasonography of abdomen, along with uroflow, urine routine, and if possible, urine culture also, sir.
Hussein,
Bridges,
our
just
pathology is
show
in
them.
the lower tract. So you have
Yes.
to say abdomen and pelvis, full bladder and post void. Just saying abdomen is not enough. You agree with me?
Yes, sir.
WBC count happens to be 20,000. Create is 1.1. Upper limit is 1.2.
Urine routine.
Okay. Soliraj, can you comment on this ultrasonography?
Yes, sir. This is ultrasound of whole abdomen, showing solid organs like liver being normal and kidney
See properly.
and right kidney left kidney mild. I'm not able to see kidney clearly, sir. If we can zoom it, it will be
See
better.
the large film. The lowermost three. The lowermost three are the kidneys. The middle is what? Ekant, can you just comment?
This is ultrasound abdomen pelvis of 82-year-old gentleman named so and so, obtained on so and so date. The liver, spleen, gallbladder are normal. The there is a
Where you are able to see the liver? Which film you just show me? Tell me. There is a first row, second row, and third row.
yes, sir, here. Third from first, sir.
So that is what? Is there a gallbladder or what is it? Is there a gallbladder with a stone inside? Just see.
Yeah, yes.
And dilated hepatic ductal system.
Yes.
And below that, what is that center one,
Uh,
which is showing increased vascularity?
sir,
Is the liver with a mass inside?
looks like a liver cyst. Could be a hemangioma.
Okay, that we discuss later. Now, what about the first row, first and second field?
Yes, sir. Sir, this the first film seems to be of the urinary bladder with an echogenic lesion with a post-acoustic shadowing, and it is mobile, suggestive of a cycle calculus.
And second field,
In second film, I can appreciate prostatic enlargement with big median lobe.
Okay, so now comments on these. Number one, Ekansh, saying mobile was not necessarily. How do you know it's a mobile thing? Okay, and second is don't call it median lobe, call it intravesical prostatic protrusion.
Okay, sir.
Okay,
Okay, sir. Yes.
so unnecessary आपने mobile बोला, उसकी जरूरत नहीं है. How do you make out it's mobile?
So I thought that they have tilted the patient वो ऐसे टेढ़ा कुछ.
ठीक है. So again, in the third row, we can see both kidneys are normal. There is a very large bladder stone. Then there is significant enlargement of prostate with a significant intravesical prostatic protrusion. What are the other things you will see on sonography which will suggest bladder outlet obstruction?
So I want to look for hydroureter, hydronephrosis.
वो तो नहीं है ना, किडनी दिख गई, नॉर्मल है.
हाँ. इस केस में prostatic urethral angle, then
Common
PCA.
things. Akash, what is the commonest thing we see in sonography of KUB? Thickness of bladder.
Bladder thickness.
Yeah,
Bladder
let's
thickness.
talk of common things. You see, prostatic urethral angle is never calculated on abdominal sonography.
On truss. Yes,
It is something which you do on truss.
Truss. Yes, sir.
Okay, so here we would want to see the bladder wall thickness,
Bladder wall
whether
thickness.
any diverticular saccage, that means irregularity of the bladder wall, and maybe if they have given, then we could look at post-void residue.
Yes, sir.
Okay.
Yes, sir.
बताइए साहब, रिपोर्ट बताइए.
Yeah, exactly what you are saying. And that is what I want Ekans or Hussein to say exactly whatever you are saying. Starting from the kidney, that the kidney appears to be normal, correct? The solid organ, that is the liver. There is a, probably a space occupying lesion seen in the liver with the gallstone and dilated biliary system. And in the bladder, as you can see, there is a large vesical calculus with the protrusion of intravesical protrusion of the prostate.
What is the significance of IPP, Akansh?
Sir, IPP or intravesical prostatic protrusion is graded into three, and it signifies the severity of the bladder outlet obstruction because of prostatic enlargement, and it has been shown to correlate with the symptoms, symptomatology, and also the bother score of the patient much more than the size of the prostate itself. And it is graded as less than grade 1 less than 5 mm, grade 2 5 to 10 mm, grade 3 more than 10 mm.
So the significance is that these are patients who are very less likely to respond to medical management, and these patients more often need some form of intervention. These needs to be kept on proper surveillance if you put them on medical management.
Yes.
As it is in this patient with the diagnosis of multiple vesical calculi, probably we are not contemplating medical management. Okay, how much is the normal bladder wall thickness?
The normal bladder wall thickness is 5 mm when bladder is relaxed, and 3 mm when bladder is stretched.
What do you mean relaxed?
Sorry, bladder is not distended, and when bladder is distended, then 3 mm.
How do you measure bladder wall thickness?
Sir, so we calculate the two weights and subtract the two weights and then divided by the specific gravity.
You are mixing up two things. You are talking about detrusor weight or bladder wall weight. I'm just talking of detrusor thickness, bladder wall thickness. Yes, so Lairaj, how do you calculate bladder wall thickness? How do you check for bladder wall thickness?
Sir, the thickness between mucosa to muscular is there and taken in 2 to 3 different places and average the value.
With how much bladder fullness?
With 200 to 300 ml of bladder volume.
So approximately 150 to 200 ml, you measure it at 3 different places and take a mean of the 3 values. Okay, and anything more than 3 millimeters would be considered as significant. Okay, so गीता साहब आपको और कुछ पूछना है यहाँ?
नहीं सर.
चलिए, what next? Solaraj, what's your next investigation now?
पोस्ट वाइड रेसिड्यू पे डिस्कशन जा सकता है, लेकिन यहाँ ब्लैडर स्टोन भी है और ऑलरेडी इंट्राप्रोस्टेटिक एक्सटेंशन भी, प्रोटोजन भी है, तो पोस्ट वाइड का ज़्यादा सिग्निफिकेंस नहीं है, तो रहने वाला है. लेकिन अगर डेफिनेशन पूछ सकते हैं सिंगल पोस्ट वाइड का कितना इम्पोर्टेंस नहीं है, कब कैसा कैलकुलेट करने का, ये सब चीज़ें पे डिस्कशन जा सकता है.
Another thing they ask is about the uroflowmetry. So now if ultrasonography is showing vesical calculus, what will be the significance or importance of uroflowmetry? Maheshwari ji.
सर पहले स्टूडेंट से पूछ लीजिए, हुसैन से पूछ लेते हैं.
Okay, Hussein, you had asked for uroflowmetry, correct? And that you had
Yes.
asked before the sonography. But now you have seen the sonography. How much importance you will give it to it?
So, sir, we can get a staining or intermittent pattern along with the bladder stone also. So, that may mislead us, sir, when we are doing uroflow along with, when the BPH along with the bladder stone is there.
So in this patient with this present sonography report, will you ask for a uroflowmetry or you will not ask?
No need, sir.
Ekansh, what do you
Is
think?
there
I'll ask because I'll need it for follow-up and documentation.
So you can always say, if you say that you have asked for uroflowmetry, you can say, "Okay, sir, it will help me in my diagnosis also." For example, it is interrupted flow, you can say, yes, it is because of the bladder stone. If the prostate is very small and in spite of that, the flow is very poor and the stone is very large, that means there are chances that he has got a bladder neck outlet obstruction. And as you said very rightly, that in follow-up, you will be able to judge whether with your management the patient has improved or not, whether you do prostate surgery or you don't do prostate surgery. So
Sir,
whatever way it is.
no, sir, in this patient already there is a significant post-void, maybe definitely due to the stone multiple. Size of the stone is already 4 centimeter. They have 4 to 2 millimeter मेरे ख्याल से. Intraprostatic protrusion भी significant है. So ऐसे सिचुएशन में आप यूरोफ्लोमेट्री करें या न करें ज्यादा कुछ फर्क नहीं पड़ता है. तो आई फील कि यूरोफ्लोमेट्री आफ्टर सीइंग दिस रिपोर्ट may not be asked.
Should not be asked. You see, if you by mistake, if Hussein, you have said uroflowmetry, the way to defend it will be that, sir, it's a non-invasive test, can be done, though my decision is already done based on this report. But if they ask you after this report, do you want to do it? Your treatment is not going to change based on the uroflowmetry. So if we have not asked for uroflowmetry up till now, patient comes with this report, we will probably not ask for a uroflow.
Agreed.
Yeah. So only thing is here by mistake, if you talk about the uroflowmetry, then how to defend that you should know.
Uroflowmetry would be important if patient had a solitary small stone with a small prostate without significant IPP, where you want to decide whether you want to intervene for the prostate also or just remove the stone. But in this patient, that discussion is not there. You already have multiple complications or changes related to BPH. You have thickened bladder, you have PVR, you have multiple bladder stones and a large IPP. So you have enough indications to intervene in this patient.
Yes. So that is why I asked them that what is the importance of uroflowmetry in this case. So now I hope all of you understood that if it is a large stone, small prostate, and you are expecting that prostate is not causing problem, in that case, you can ask for a uroflowmetry. But in this case, it is not mandatory. It is not required. Okay, what else you want now? Ekant, what else you want?
Sir, I want to serum PSA, sir.
Okay. Bridges?
Why you want serum PSA? Tell me one indication for serum PSA. One indication. If it is there in this patient with this presentation.
So in other way, if the PSA is raised, then what are the causes of?
Sir, because of him being 82-year-old male.
तो इसमें PSA रेज आने PSA 80-year-old है, क्यों करना है PSA? क्या करने वाले PSA करके? What for? What if you are for why you want to do PSA in this patient?
You see, to do PSA, you should have a life expectancy of minimum 10 years.
Exactly.
At 82 years, so that is one negative point. The second negative point is this patient already has infection. Infection itself has a potential to raise PSA. And even if suppose, luckily it has come 1.21, but if it were suppose 12.11, would your treatment plan in any way change? Then are you going to do a MRI of this patient or do a biopsy for this patient?
It will only increase your confusion.
Correct.
Okay, so in this patient, if suppose examiner asks you, do you want PSA? You should say, in view of his age and the presentation with infection, this is not the right time to get the PSA done. And as it is clinically, it is benign, I'm not suspecting malignancy.
Correct, sir.
So I hope all of you understood that we have got lots of investigation in our armament, correct? But that doesn't mean that every investigation should be done for every case. In some patients, you may do all the investigation, but in some patients, you have to reserve and only few investigations which are going to help you to take your decision for a diagnosis and management. You understood? So, for example, in this case, uroflowmetry doesn't have much of the role because it is not going to change your diagnosis or it is not going to change your management. The same way PSA. So, in this case, PSA is not required. Okay? So,
Yes.
every time you get a case, that doesn't mean that you have to do all the investigation.
Yes.
Fine. So, now what you will do for liver malignancy? Very simple.
First, we have to
This is not under
correct.
your domain. Yes, Solai, right? What you will do?
As this is not in our domain, we'll refer the patient, sir. Otherwise, we can do
Correct.
three triple phase to find the characteristics of the liver lesion.
Yeah, so you leave it to
Don't get
gastroenterologist.
into that at all. Okay.
Yeah. Just say that, sir, I'll refer patient to gastroenterologist. Finish.
Yes, sir.
Or hepatobiliary surgeon.
Yes, sir.
Okay. Fine. So what else you want now? Any other investigation to help you in deciding your treatment or anything else? Amit?
Sir, from my side, at this stage, I want to admit the patient and start on antibiotics and stabilize the patient. And then accordingly, I will take the further call once the
Okay.
patient is stabilized, sir.
Okay, fine. So because you are saying that patient's WBC count is very high, 20,000, 22,000, correct? You want to admit and
Yes.
start the higher antibiotics.
Yes, sir.
Okay, fine.
And meanwhile, I can put the patient on catheter also, so that the infected urine can be drained and uh, further measures can be taken up in the near future, sir.
So Ekant, you agree with him? You will like to put the catheter?
Yes, sir. Yes, sir.
Hussein?
Yes, sir. In view of raised PVR, catheter can be indicated, sir.
Okay. without catheterization, with a good antibiotic cover for 2 days. Can you give the definite treatment? With such a big stone, what are the chances that you will be able to drain the full bladder? Solaidas?
Sir, once the liver lesion is ruled out from our equation, like we can do catheterization and then treat the patient with IV antibiotics, and then we can wait for 2 weeks to stabilize the patient, and then we can go for surgery.
See, except for WBC count, this patient doesn't have any other symptoms suggestive of any, urosepsis or any other feature. So, in this case, I am not very sure that I will put the catheter, but I will take opinion of Dr. Maheshwari and Dr. Gite, because with such a large stone, even if you put a catheter, the balloon may not, will keep the catheter up only, and there are chances that you may not be able to drain the full bladder. Dr. Gite, what is your view?
So, he may not be having a fever or clinical symptoms of sepsis, but the post-viral should be significant and TLC is raised. So, two bladder should be drained by placing the catheter. He may not pass the urine with free flow, and hello, he may not pass the urine with free flow because multiple small stones. Hello.
Yeah, Manas, you want to say something?
So given in this case, I will place the catheters.
Okay.
Even I would agree, sir, that this patient, in view of the recent infection, raised total count, we would not want to intervene immediately. We would want to give it some time before the infection stabilizes, patient is optimized. So it is better to place a catheter so that we get chance and time for optimization of the patient. So Brijesh, what was done?
Is likely said, we admitted the patient, started on antibiotics, sent the urine culture again. Then patient was counseled, but because patient also had liver mets, we did liver mass, we did CT.
Okay. Just Bridges, show them the X-ray also. And I want to ask, in exam, shall we talk about X-ray or not?
Which X-ray, sir?
X-ray pelvis, X-ray TUB. For the stone, because I normally like to do, it just helps me, it shows that how hard the stone is, how big it is, because many a times by sonography, you are not able to visualize or conceptuate that whether you can, what exact management you will like to do, because it is 4.5, and the sonography is saying multiple stones, but here you can see. So Ekant, can you just comment on this X-ray?
Sir, so this is the first one is X-ray abdomen. Second one is X-ray KUB of this patient, showing
KUB or pelvis, second X-ray. Can you see the kidneys?
correct, sir. Sorry, this is pelvis only. X-ray pelvis. X-ray pelvis, and the first one is only abdomen.
Okay.
And and it is showing multiple calculi. But
Where are the multiple calculi? In the kidney or in the bladder?
Multiple calculi in the bladder, sir.
In the bladder? It is one calculi or multiple
Dr.
calculi?
Anas, can you mute yourself?
No, sir. So there are multiple calculi, multiple large calculi. One is the largest, about 2.5, about 2.5 at least, larger than 2.5 centimeter.
Manas.
Yeah, I have muted it.
Good. So, who is reading this X-ray? Sorry, I missed everything.
Sir, the
Yes.
first one is X-ray abdomen, and the second one is X-ray pelvis of this patient. It shows, multiple bladder calculi with the.
Are you sure it is multiple bladder calculi? Please see again. What you are seeing, that other shadow that you are seeing, is it in continuation with something else?
It is in
This
continuation.
this
Bowel.
X-ray is post contrast city or pre contrast city.
Yeah,
अगर उन्होंने सिटी किया है तो
exactly.
Post contrast, yeah.
ओरल कॉन्ट्रास्ट
So
दिया
that
होगा
is,
ना, इसलिए कोलन पूरा दिख रहा है यहाँ से वहां तक.
so whenever you see this X-rays, understand, sometimes, many a times, like if I am an examiner, and if I have got such X-rays, I like to put it. Why? Because from this, I can make out that, how often you are looking at X-rays, whether you are discussing with your colleagues in radiology department or not, or you are having a clinical diagnosis or not. This is very important.
Yes, sir.
So there is only one large, because see, you had read ultrasonography, and ultrasonography was showing multiple calculi. That is why you were under the impression that bladder has got multiple calculi. But here there is only one large stone. Okay?
Yes, sir.
Fine. Okay.
So simplified, वो अगर post contrast city है, the purpose of all purpose of doing a X-ray is already available with CT scan, because non contrast city उसमें रहता है. अगर हॉस्पिटल यूनिट भी चाहिए, नंबर ऑफ स्टोन्स, इफ इट इज मिस्ड इन द किडनी, स्मॉल छोटा सा मिस हो सकता है सोनोग्राफी में, वो भी सिटी में पिकअप किया जाएगा. तो सिटी के बाद में अगर एक्सरे कर रहे हो तो दैट मे नॉट बी रिक्वायर्ड. If you are not doing CT, and if you just want to confirm is there any another radio opaque stone, then if you want to do a confirmation of stones, then better to go NCCT KVP, not for the X-ray KVP. देन उसमें पूरा पता चलेगा, फिर हॉस्पिटल भी पता चलेगा, छोटा सा स्टोन किडनी में सोनोग्राफी से मिस हो गया तो वो भी पता चलेगा. अगर करना है तो नॉन कॉन्ट्रास्ट सिटी स्कैन करो, और ये पोस्ट कॉन्ट्रास्ट अगर कर रहे हो तो एक्सरे के भी इज नॉट इंडिकेटेड, नॉट रिक्वायर्ड एट ऑल, बिकॉज द वॉट एवर द इंफॉर्मेशन यू वांट टू नो, that can be gained by the CT scan. Pankaj sir.
Fine. Because I think he had a liver lesion. CT was done. Yes, Bridges, can you just show them? We have done CT scan. Okay, this is the uroflowmetry. Any one of you? Solaidas, can you just comment on CT? And Ekant, can you comment on uroflowmetry?
Yes, sir. So here CT is shown.
Yeah, Ekant, CT shows CT scan. Bridges, show CT scan to Ekant.
Yes, sir.
Yeah. Ekant?
Yes, sir. So this is
Hussein, you want to try?
so this is a contrast enhanced CT scan of this patient, and it shows bilateral kidneys normal with no hydronephrosis, hydroureter. Bilateral ureters are normal in course and caliber. There's bladder wall thickening, and there is one calculus towards the base of the bladder, and
Okay.
single calculus.
And what is next to it?
So there's median lobe enlargement, intraprostatic, intravesical
Intravesical.
intravesical
Intravesical protrusion of the prostate.
protrusion.
Okay. Yeah. And if you can see the liver, you can comment.
And bilateral kidneys are normally functioning and normally excreting contrast. And in the liver, sir, in the liver left lobe, there is a liver left lobe, there's a lesion. So for that, we'll have to do
No problem. I am Brijesh, just show them the report.
So there is hepatomegaly with hepatic steatosis, large hypodense mass seen in segment 8 of the liver with enhancement suggestive HCC and correlation with AFP level is suggested. Large hypodense collection abutting the left proximal common iliac artery in smaller collection superior mild to moderate ascites in left parabolic gutter with thickening of the renal fascia. Cholelithiasis is also seen without acute cholecystitis or cholelithiasis. Bilateral adrenal adenomas are seen. And a large calculus is seen in the bladder with a small Hutch diverticulum along the right lateral wall of the urinary bladder with prostatomegaly.
Okay. So now just so uroflowmetry. Yeah, Amit, can you just correlate? Can you just tell about this uroflowmetry? And can you just correlate this uroflowmetry with the patients?
Yes, sir. So
This patient.
this Europhometry curve is showing the prolonged blunted pattern, but a well-maintained bell-shaped curve. He has voided 350 ml of urine with the uh, Qmax of 15.7 and average flow is 5.3 with the prolonged voiding time of 132 seconds. Yes, sir. It's a prolonged blunted pattern suggestive of bladder outlet obstruction, which can be due to the prostatomegaly.
Okay, and there is some interrupted flow in between.
In between,
That
yes, sir.
means
There
that
is
is
interrupted.
suggestive of
Median
either
lobe
the median
enlargement.
lobe enlargement or like in the stone, in the
And
bladder
understood.
vesical calculus. You see this. And if it is multiple, then in the neurogenic bladder. Okay, fine.
Yes, sir.
So now what you want to do?
Sir, regarding this
Amit, I am
liver,
asking you a simple. After seeing all these things, I am giving you two options. Number one, you want to operate only stone. And number two, you want to operate stone and prostate. And the management, to all of you, I'm saying, and the management is, if you are operating only stone, then whether you want to do perurethral procedure, okay, suprapubic cystolithotomy, or you want to do percutaneous, like, cystolithotony in this case, that is stone. Again, if you want to do stone as well as prostate, what are the different ways, which one you will like to do. And third, whether you want to do in the same sitting or in the stage proceed. So Hamid, you tell me what you want to do.
Yes. Sir, Brijesh, can you tell me the size again, please, of the prostate?
Prostate was 72
42.
grams, huh?
42
Pardon?
grams.
42.
42
Sorry,
grams.
42.
So I want to do the uh, if
He has got residual urine, huh? See, we have already
yes, sir.
discussed that he has got a residual urine.
Yes, sir. I want to do the stone and prostate in the same sitting, but the stone by the PCCL route and place the SPC and do the enucleation of the prostate with the laser, sir.
How do you refer?
How much is the size of prostate?
42, sir.
So why you want to go for laser, as it is available with you only? What are the indication for laser prostatectomy?
Sir, greater than
Doing a laser for 42 may not be wrong practically, but theoretically, what are the indication for laser? Use of laser in prostate.
sir, if the patient is on blood thinner, then we can we can use the
But this
laser
patient is not on
prostatectomy.
blood thinner.
Yes,
This
and
patient is
the
not on blood
gland
thinner.
size is gland size is in between 30 to 80 grams. Then also we can 40 to 80 grams. Then also we can use the do the laser prostatectomy and up like yes, sir.
So indication
So
for
what is the gold
laser
standard?
prostatectomy is 40 gram prostate. Pankaj sir.
So,
No.
Hamid, the thing that you see, uh, if you have now said laser, the way to defend laser would be that laser is a size independent technology
Yes.
for BPH. So understand what sir is trying to ask you and understand where sir is taking you towards. Sir is trying to take you towards a direction which says that laser has an advantage for large prostates. So you should have said here that yes, laser would be ideally indicated for patients with large prostates, but even in small prostates, I can do it because as per guidelines, it's a size independent technology.
Okay, sir.
So
So
देखिए एग्जाम में लेट्स नॉट बी वेरी रिजिड. हम साथ साथ में एग्जामिनर क्या सोच रहे हैं हमें वो भी सोचते रहना है. सर के पूछने का रीजन यही था कि भाई लेजर का एडवांटेज बड़े प्रोस्टेट में है. हमको वो समझ के पहले सर को आंसर देना है कि यस जो आप कह रहे हैं बिल्कुल सही है पर हम इसलिए कर रहे हैं.
देखो, the ideal answer in this patient, first answer in this patient is PCCL with TURP.
Yes.
Okay. अगर आप पूछा एग्जामिनर ने कि यस आपके लेजर अवेलेबल है, करेंगे नहीं करेंगे, देन यस.
Okay,
अब दूसरा प्राइमरली और डिफेंड करने का तो लेजर का स्टोन में भी बेनिफिट है. इतना बड़ा स्टोन अगर फोड़ना है तो न्यूमेटिक से फोड़ने के लिए जितना टाइम लगेगा शायद उससे कम टाइम लेजर से लग सकता है. तो दैट आर द पॉजिटिव पॉइंट्स टू TURP से मेरा काम बन जाएगा. अनदर थिंग इज लेजर एवरीवेयर अवेलेबल नहीं है. TURP सब तरफ अवेलेबल है. तो दोनों
Yes.
तरफ से डिपेंड कर सकते हैं. लेकिन एज अ स्टूडेंट अगर आप बोलना चाहते हो एग्जाम में तो PCCL विद TURP दैट विल बी द बेस्ट आंसर. एग्जामिनर अगर लेजर रेगुलरली करने वाला है या फिर एग्जामिनर लेजर की तरफ लेके जाना ही चाहता है तो फिर वो भी डिपेंड कर सकते हैं.
Okay.
I 100% agree with what sir has said that in exam, if it is a TURP like gland, means any gland less than 60 grams, first try to go towards TURP. You see, most examiners would feel that to be qualified as a urologist, you should know everything about TURP. So first let's talk of TURP. If they ask you other options, then keep that as a second line option. in practice, what you do would depend on what facilities you have and many other factors. But in exam, any gram less than 60, any prostate less than 60 grams, start by talking about TRP.
Okay.
And because
Fine.
this prostate is very large, more than 4 centimeters, do not talk of urethral cystolithotrity, talk of PCCL.
Yes.
So, Hamid, if you are doing PCCL and TRP, what you will do first?
The PCC I will do first.
Why?
Sir, that will help me to place the SPC, and the TRP can be done under low pressure along with the continuous irrigation sheet. So the pressures can be maintained lower, and yes, sir.
Fine.
And yes, sir.
Second,
And the vision will be better, and bleeding will be yes. The vision will be better, and low pressures will be there.
So yes, don't talk of bleeding. Bleeding does not depend on your
Yes, sir.
suprapubic catheter.
Yes. Yes.
Okay. So suprapubic catheter will only help by keeping low pressure irrigation so that fluid intravasation is low.
Yes.
and second important thing is that first, if you do TRP, you are creating a raw area. And then if you are breaking the stone, okay, then these small fragments or something may get stuck, which may be later on difficult to remove from that fossa.
Okay.
So always what you are saying is right. Now my question is, Sulay, that if you want to do, if I tell you, okay, you do open and finish both the cases in open surgery, can you do it? Number one. And if you are doing it, what surgery you will do? Okay, suppose if you have to do open surgery, I will put it in a different way. Then, if you want to do stone removal also and you want to remove the prostate, which is the ideal way of doing it?
Transvesical, sir.
Pardon? Yes, transvesical. What is the name?
I'm not sure, sir.
Yeah, Ekam. What is the name of the surgery?
Fresh prostatectomy.
Yes.
So, okay. So, but in this case, will you advise prayers or open surgery?
No, sir, not in this case because because it's a 42 cc prostate, plus the patient is very old. He'll be frail. He will have multiple comorbidities, and it will be a big surgery it will be big surgery for him to tolerate.
Correct. So, if it is a like 80 gram, 90 gram
Ekant, hold
prostate,
on.
Yeah.
You have all the details of this patient. Why are you saying patient will be frail, patient will have comorbidities? You know what all this patient has. There are no comorbidities in this patient.
Complication of open Freres prostatectomy and complication of TRP. कौन सा अच्छा है?
Complications of open are less.
Less. अपने इसका मतलब ओपन देखा ही नहीं है कभी.
Which may be true, Dr. Gite.
मैं गारंटी से बोलता हूँ कि इसने देखा नहीं, क्योंकि देखो एक तो साइज ऑफ ग्लैंड TRP के लिए एलिजिबल है, नंबर 2 मिनिमल इन्वेजिव प्रोसीजर है, कॉम्प्लिकेशन होने का चांस नहीं होता है ऐसा नहीं, हो सकता है, लेकिन कंपैरेटिवली जो कॉम्प्लिकेशंस ओपन में हो सकते हैं वो इसमें नहीं होंगे. पोस्ट ऑपरेटिव रिकवरी डेफिनेटली मिनिमल इन्वेजिव रहने की वजह से, एंडोस्कोपिक ट्रीटमेंट रहने की वजह से इसमें अच्छी है, तो क्यों करेंगे ओपन सर्जरी? और स्टोन के लिए आप ऑलरेडी PCCL करने वाले हो, तो ओपन देखो until and otherwise it is समझो 120 ग्राम प्रोस्टेट with some big diverticulum, चाहे 120 ग्राम प्रोस्टेट है और 4 सेंटीमीटर का भी स्टोन है, जो कि लेजर के लिए भी ज्यादा टाइम लगाने वाला है। कुछ कुछ तो ऐसा क्लासिकल इंडिकेशन रहना चाहिए जो हम डिपेंड कर सकेंगे।
So, like Gaurang Bhai asked you this question, you should say that this patient probably is not a good candidate for open. We will do a PCCL followed by TURP because it's a very small gland, easily manageable by endoscopic treatment.
Yes, sir. Correct.
Perfect. Yes. Okay, so Hussein,
Yes.
instead of doing PCCL, means I say that why to do PCCL? It will take the longer time. Instead of that, I will make a small incision. I will do TRP and then make a small incision and just remove the stone. What you will prefer?
Means you meant to say, sir, you want to do first TURP, then PCCL.
Yeah, TRP and then just make a small incision and remove the big stone.
So, sir is saying TURP followed by cystolithotomy.
Cystolithotomy. So, sir, if we are doing TURP first, then there is a possibility of bleeding and we may postpone the procedure. So
Okay.
that is a one drawback that
So the same thing in the PCCL also. The bleeding, if you are, first you are going to do, in that you are going to do that surgery, PCCL, correct? And then you are going to do TRP. So if suppose some complication takes place, you are going to, if you take a longer time or if you feel that there is some trauma to the bladder, any complication can take place, then you might have to abandon the further procedure. But here, if you do TRP, what are the chances of bleeding in such a small gland with an even in a little good experience? Nowadays, all of you are seeing on the screen, even if you have done a less number of TRP, still you can do channel TRP and you can stop the bleeding and you can just go ahead. It will take hardly, any time. But in such a hard, big stone, PCCL may take a longer time. And to remove all the pieces, how you are going to remove the pieces? Suppose if you are doing PCNL, such a big stone, how much time you will take? Hussein,
sorry, sir, can you repeat?
if you are, suppose the same stone, you are going to do PCNL, how much time you will take?
So, sir is saying if this stone is in the kidney where you are planning PCNL, how much time will lithotripsy take?
Sorry, it will take around 1.5 to 2 hours, 1.5 hours at least.
So 1.5. So here also, it will take approximately that much time to do PCCL. But if you do open surgery, it will be half an hour. Why not to do open? Just remove the full stone.
So by doing open, sir, the morbidity at this age, the morbidity will increase also, sir, for this patient. So
You are not going to do muscle cutting.
So, Hussein, you see, when you are faced with such questions, remember first to agree with the examiner. Okay, you have to say, sir, yes, it
That's
can
the
be
best
done.
advice, Pankaj bhai. That is the first best advice you are giving.
Okay, first you say, yes, it can be done, and then say, sir, I would prefer PCCL because, come back to PCCL. Minimally invasive small incision with a 30 French Empla sheath. Why will you take 1.5 hours of lithotripsy time for a 4 centimeter stone with a 30 French Empla sheath?
right, sir.
Okay, so exam may don't get rigid. If examiner is taking you somewhere, first agree and again come back to your point. Can be done? Yes, can be done. Sir, but I still prefer PCCL because of 1 to 3 reasons. अब नहीं तो क्या होगा, देखिए फिर ये अब कैस्केड शुरू
है
किया
गाड़ी वहीं पे
कि मसल स्प्लिटिंग नहीं हो सकता है क्या, मॉर्बिडिटी ज़्यादा नहीं है. So then you get into a very different type of debate which you don't want to get into.
ये वो पेशेंट तो बोल रहा है पूरा इंटैक्ट स्टोन निकाल के दे दो, क्या करेंगे फिर? ऐसा बोले तो गाड़ी फंस गई वहीं पे, फिर जाता नहीं किधर।
So
तो
my
पहले
question of asking all different thing is that all these different possibilities are there, whether only stone, only prostate and both together, or in the stage, because it depends upon the different patient. So sometimes you might have to do one of the procedure, or sometimes you might have to do a stage procedure. So that is why I am asking you. Okay, in this patient, now you decide what you want to. So as you have agreed that we will do PCCA followed by QR, but you can also do cystolithotomy in this case. Whichever you want to do, you should know how to defend, because either way you can defend it. Understood?
but in exam there are 3 to 4 permutation combination will come, that like large prostate large stone, large prostate small prostate small stone, ये 3-4 कॉम्बिनेशन आते हैं। उसका आंसर क्या बोलना है वो सोच के रेडी रखना है, दैट आंसर शुड बी एक्सेप्टेबल टू एवरीबडी। उसके बाद में जो भी हायर वर्जन है तो फिर उसमें फिर ट्रांसवसाइकल लैप्रोस्कोपिक स्टोन क्यों नहीं निकालेंगे, फिर ट्रांसवसाइकल लैप्रोस्कोपिक प्रोस्टेटेक्टोमी भी कर सकते हो, रोबोटिक कर सकते हो, कुछ भी कर सकते हैं, करने का है। लेकिन कॉमनली एक्सेप्टेड आंसर क्या है वो पहले बोलना। अगर एग्जामिनर का मूड है कि भाई उधर जाना ही है ओपन सर्जरी की तरफ, तो एक्सेप्ट कर देना, सर ने जैसा बोले वैसे, यस सर इट कैन बी डन। तो उस पे उसके भी 2-4 बेनिफिट्स बोल देना, फिर दैट ही विल बी मोर हैप्पी।
So as sir said, small stone, small prostate, you will do transurethral, both the things. If it is a small prostate, very big stone, then either PCCL or open surgery and QRT, like in this case. If the prostate is also very big and the stone is also big, or the multiple stones are there, you can say that I will like to do prayer. Or again, laser surgery or and PCCL or suprapubic cystolithotomy. Okay. So like this, you have, and the stone is very small and the prostate is very big. You can do cystolithotreating. Along with that, you can do laser, or depending upon how big it is, you can talk of open surgery. So as sir has said, these are the permutation combination of different prostate and stone, vesical stone surgery. So you must write down all the combinations, and in exam answer accordingly.
Sir,
Gite
I
sir,
want to ask
बरोबर
two
आहे?
questions, sir.
Go ahead, Amit.
Yeah.
Sir, as this patient is presenting with the complication of bladder outlet obstruction, he is the patient for the surgery in the near future. As per the indications of urodynamics, a patient with lower urinary tract symptoms, age greater than 80 years, and we are planning for the surgery. Should we do the urodynamics, or if the examiner asks, or what should we say in this patient? And yes, sir.
So you want to do urodynamics with stone or without stone? Then I will ask another question.
Sir, ideally, the urodynamics should be done without the stones. But in this patient, when we are going for removal of the stone, then uh, we shouldn't wait for the urodynamics to be done and then accordingly remove the prostate.
तो ये पेशेंट में यूरोडायनामिक करेंगे विद स्टोन की नहीं करेंगे, उसका आंसर
It
क्या?
shouldn't be done. No, sir.
Then when you will do urodynamic?
Sir, ideally, urodynamics in these patients should be to be done. Then that will decide how the patient will respond post procedure, sir. If we need to keep the catheter for longer
सिंप्लीफाइड
duration.
है, वही बता रहा हूँ मैं आपको कि आप ये स्टोन के साथ करेंगे कि नहीं करेंगे? नहीं करेंगे। कब करेंगे? स्टोन निकाल दिया, प्रोस्टेट निकाल दिया, बाद में अगर जरूरत है पेशेंट पास नहीं कर रहा तो देखेंगे।
Okay, sir.
So, Hamid, let me explain it to you where the small thinking error is happening. If there is some absolute indication for intervention, say you have this patient who would have come with bilateral hydronephrosis with a creatinine of 5, where you have put in a catheter and decompressed the kidney, obviously you need to operate irrespective of urodynamic findings. large stone, which looks a secondary stone, obviously we need to operate. So if there is some absolute indication of surgery, even in an older patient, you do not need urodynamics. But now let's take another patient who has come with, say, mild to moderate symptoms, 15 ml flow rate, 42 gram prostate, and a 12-13 millimeter IPP. This probably would be a patient where you want to do urodynamics to decide whether the patient needs intervention or should I intervene or not. So if there is a clear indication for intervention, then don't think of urodynamics at this time.
Okay,
And do not suggest urodynamics in presence of infection, in presence of stone.
okay, sir. And second question, sir. As there is a clear-cut demonstration of stone with posterior acoustic shadow on the ultrasound, should we like comment on the NCCT KOB, sir? Like if the kidneys are looking normal and
If your
everything is normal, just a stone in the
ultrasound report, if your ultrasound report clearly suggestive of there is no stone in the rest of the system, and if you are happy with your ultrasound report, no need. If your ultrasound report is equivocal, still you want to rule out some small stones in the upper, in the both the kidney or ureter, and वैसा कोई क्ल्यू है अल्ट्रासाउंड में तो एनसीसीटी करना है, अदरवाइज करने का कोई जरूरत नहीं.
Yeah, Amit, don't get confused with it. In this case,
अपन एक
the CT
एनसीसीटी
scan
का
was
डिस्कशन
done
इसलिए आया क्योंकि एक्सरे क्यों
because
भी
of
किया था,
liver.
और एक स्टूडेंट ने बोला कि वो स्टोन का सॉफ्टनेस हार्डनेस कंफर्म करना है, तो वो एनसीसीटी पे ज्यादा कंफर्म हो जाता है कंपेयर टू एक्सरे के.
Yeah,
रूटीनली
yeah,
हम
and
एनसीसीटी क्यों करेंगे अगर ऊपर स्टोन नहीं है और सोनोग्राफी अगर क्लियर कट बोल रहा है कि ब्लैडर स्टोन ही है और प्रोस्टेट ही है तो.
then
okay,
I agree. I'm just explaining. In this case, it was done because of the liver problem. It was
That
not
true sir.
done for the
In this
prostate.
case it's okay. कॉन्ट्रासिटी
Yeah,
भी
that's
करना
what I'm saying.
पड़ेगा उसमें.
Otherwise,
एक्चुअली
in other cases, yes, other cases it's straightforward.
ट्रिपल
Just
कॉन्ट्रास्ट किया है, ओरल रेक्टल एज वेल एज आईवी कॉन्ट्रास्ट का सिटी था वो. एक्चुअली वो बताना चाहिए था.
yeah, correct. So don't get
Uh,
confused. CT
So,
scan
पंकज सर,
has
एनी
got
डेविएशन उसमें
no,
एनसीसीटी रूटीनली तो जरूरी नहीं ना.
Absolutely not
no.
indicated, sir.
I think only sonography maximum I like to do is the X-ray. Just it gives me a visual. I am little old timer, so it gives me a visual effect that whether this patient can be operated per urethral cystolithotrophy can be done, because many times they say 2.5 centimeter, 3 centimeter, and when you take an X-ray, you feel no, it's too big. It's not worth doing per urethral. You may damage the urethra, and you will go for percutaneous cystolithotrophy. So like that. So I like to do only X-ray, and it is a non-invasive, not very costly, and everyone anywhere it is available. One X-ray is not going to make any difference.
okay.
Sir, I have a question.
Yeah.
Sir, if this is a single stone and QMX is that is around 15, so can we consider this PVR due to the stone, and can we put him on medical management?
Which stone?
Yeah,
If
this
it is a
patient. So okay.
You-
I'm asking you, sir, Gite sir. Let me ask you. So I gave you an option, no? Amit, that you want to only remove the stone, because I will show you this graph also. There is a regular urine patient has got infection. Now you tell me, you want to remove only stone? What is your gut feeling?
Me, sir.
That this
And suppose after removal of the stone, patient cannot pass urine, patient will come with retention, what you will do? Is it a small, very
No.
small prostate?
No, so this such type of situation may occur, like if the small prostate, no post-void residue,
Yeah,
no voiding symptoms for longer time. If it feels that there is a drop down stone from the kidney, छोटा सा stone है, तो उस टाइम पे सिर्फ सिस्टोलिथोट्रिप्सी करना कोई गलत नहीं.
No. In this case, he is asking in this case, he is saying that this post-void residual urine may be secondary to stone. Is it worth doing both the surgery, or we can just do stone surgery and then wait? That is his question in this case.
So, Hussain, this patient has a 2-year history of lower urinary tract symptoms. There is a large prostate with significant IPP, and it's a secondary stone with thickened bladder. So, I have ample indications to intervene for the prostate. As Gite sir said, if there was a specific patient where there are no other hints to treat the prostate and you just see a stone, then probably remove the stone, treat prostate medically is justified.
Yeah. If you see the last, Pankaj bhai, if you see the last series, okay, we have presented a similar thing where there was a large bladder stone. Prostate was also little large, but there was hardly any residual urine and no infection otherwise. But patient had lots of storage problems, and the flow was very good. So we have done only systolic PT, even though he was 78 to 77 years old. So as you are saying, there are definite indications, but in this case, there are already many indications to do. Even if suppose there was no vesical calculus, there are enough of indications to do the prostate surgery. Yes, Amit, any other question?
No, sir. Thank you.
Okay, then one short here, Brijesh, just give the history and the investigation. We'll just go on the management discussion. Second case.
A 77-year-old male present with the complaints of increased frequency, overflow, and nocturious environments.
So go fast.
Yeah, symptom with overflow, increased frequency, and sense of incomplete voiding. PIS-1 score is 16/35. Significant impact on daily life, and the symptoms were severely bothersome. No previous history of any hematuria, lithuria, no any abdominal pain, nausea, vomiting, facial pain, excessive breathlessness, or lower limb edema, no bony pain, no weight loss. So he history of TURP in 2013. Otherwise, he didn't have any comorbidities. Rest three prostatic enlargement. No any nodularity, smooth surface, rectal mucosa mobile. Per abdominal examination also normal.
Okay, fine. So Hamid, just tell us what are the investigations you want to do.
So I will investigate the patient with CBC, then renal function tests, blood sugars, urine routine, urine culture, uroflowmetry, and serum PSA.
And not ultrasonography?
And ultrasonography, abdomen plus pelvis with pre and post void residue.
Okay, fine. See,
So PSA is
So-
19.8.
so PSA was 19.8 and platelet was 1,20,000. Creatinine is marginally raised.
1.6. Upper
That is
limit
1.6.
happens to be 1.2, sir.
Yeah, so it is raised.
And
Show
HbA1
them other investigation. Show him other investigation. Yeah. So first test are 7 to 10. Culture done. So no growth. Fine. Ultrasonography and uroflowmetry. So Hussein, can you comment on that? Fast. Just positive finding without saying anything. So Laira,
Sir, this is ultrasound KEB of KEB region. Kidney, right kidney looks normal, left kidney looks shrunken. Right side corticomedullary differentiation is there, left side corticomedullary differentiation is lost. And bladder in thickness, UV wall thickness looks normal. Prostate is enlarged with nodular prostate, and echogenicities are like different, isoechogenic as well as hypoechogenic prostate. And IPP is very like intravesical protrusion of prostate is very less, like around 2 to 3 millimeters. Post-void residual urine looks like less than 50 ml.
Okay, Bridget, fast. Finding.
The left kidney is small with heterogeneous ecotextures. CMD is ill-defined. Prostate is enlarged 124 cc. 2 hypoechoic areas are there, and there is mild increase in vascularity, suggestive of mild prostatitis. Bladder is distended. Wall thickness is normal. Volume is 230, and post-void is insignificant.
Okay. Urophromatory, just show them urophromatory. Yeah. Hussein, can you just comment on that?
So, sir, this is a uroflowmetry where the patient is voided of 190 ml, and the pattern is intermittent along with the staining pattern, where this Qmax is around 16.5, and this average flow rate is around 4.4, sir.
In the voiding flow time is 187. Next. No, 55. Almost 180. Fine. Okay. So now what? Hussein, what you want to do?
Sir, just can you show me the DRE finding again, sir? Whether it was a tender
By
prostate or
DRE
not,
finding
sir?
it.
And
So, sir, is the raised PSA with clinically benign prostate, sir? I would like to do, sir, MP-MRI prostate, sir.
Okay. This is what we have done.
so I would read the MRI. Gross prostatomegaly with
Hmm.
post-ERP status. Wedge-shaped abnormality to hypointense signals in both peripheral zones with the apex and glandular level without diffusion restriction. So suggested of chronic prostatitis.
Yes. So Hussein, now what?
Whether any alpha blocker is going on or not, sir?
Pardon?
Any history of alpha blockers going on previously?
Why did you ask this?
Sir, as there is a history of benign enlargement of prostate along with this.
So why are you
LUTs.
interested in alpha blockers?
Is there any voiding symptoms there? I just want to check again this history part. What is the voiding symptoms exactly?
He has got voiding symptoms.
So they have said that
IPSS code
it's
is
a
16.
significant bothered symptoms with IPSS of 16.
Okay. So, sir, with these IPSS along with this bothersome LUTS along with this enlarged prostate, sir, with this Euroflow showing that Qmax is more than 15, that is suggestive that there is not significant bladder outlet obstruction, sir. So first, I would like to put him on anticholinergic.
Ekant, what do you want to do? You want to put the patient, he is operated in 2013, he has got 125 cc of prostate, he has got a bothersome symptoms, 16 by 35, and
MRI showing 157 cc prostate.
157 prostate. Yes. Second, what you want to start a medical line of management or you want to operate? I think Ekansha is left. Kolairaj, what you want to do?
Sir, in MRI report also they have mentioned serum prostate, like PSA as 19.6, sir. So before doing any management, it is better to go for a trust-guided biopsy and then to rule out any malignancy, then go for
Then Kolairaj, then why you want to do MRI? Directly do see your biopsy. No? If you don't want to rely on MRI, then what is the specificity and sensitivity?
No, explain, Solaraj, why do you want MRI? Why do you want biopsy? Sorry.
Sir, it is a recurrent prostate, like with raised PSA.
So he had a TRP more than 10 years back.
Yes, sir.
What is the risk of recurrence post TRP at 10 years?
More than 20%.
So then why should you suspect malignancy in this situation?
So, Sorairaj, if I tell you that time the prostate was 240 grams.
Sir, can I ask one question, sir?
Yeah, please.
PSA density.
Sir, in this case, before asking for MRI, can we say that we want for a period of time like 2 weeks or 3 weeks and repeat the PSA and then accordingly take a call?
So
directly.
आपकी बीच में आवाज कट गई थी. Can you repeat what you have asked?
Sir, in this case, before asking for a MRI, as this patient underwent the TURP in the past and that was benign, can we ask, can we say that we want to give the antibiotics for 2 to 3 weeks and then accordingly repeat the PSA and then take a call for the MRI?
Okay,
Yeah,
so this question of giving antibiotics and repeating PSA, unless you have clear picture of infection, do not give a trial of antibiotics. Now this patient urine routine was normal. There is no history of dysuria, burning urine or fever, and urine culture was negative. So how is antibiotic going to help you?
Sir, on the sonography, the
Sonography, you see, take
there
that
are
report.
changes.
Take that report with a pinch of salt. If you look at that sonography again, they have shown two focal areas of 9 and 10 millimeters, and they have diagnosed it as acute prostatitis. Okay,
Yes.
or mild prostatitis. That is the word they have used.
Yes.
If it is mild prostatitis, there will be hypervascularity all throughout the prostate, not in two focal areas. And again,
Okay,
mild prostatitis would be more of a clinical diagnosis on DRE. If patient would have any tenderness or any other features. So in this patient, I would not really go by that report because that report is not suggestive of mild prostatitis.
Okay, sir.
So now in case like Hussain said, if suppose your plan is to initially give him a trial of medical management and you decide to put him on alpha blockers, then maybe if you are waiting, you could repeat a PSA after 4 weeks. But in this patient with significant symptoms, recurrent growth, such a huge prostate, Flow rate, though it is on paper showing 16 ml per second, but if you see, there is a significant straining pattern, there is a very, very prolonged void, there is intermittency, there is significant amount of hesitancy. So even flow rate is suggestive of blood outlet obstruction. So this patient, you have to suggest intervention. So suppose patient says he's not keen and wants to try medicine, you could always put him on medicine. But again, if you decide to put on medical management, do not put him on dutastride or 5-alpha reductase inhibitors, because we do not want PSA to come down by medications. We want to monitor that PSA. So if suppose you decide medications, then alpha blocker, repeat PSA after 1 month. If you decide to intervene, because you are going to intervene, it is important to do MRI to confirm that we are not faced with a situation where histopath comes as malignancy. With a MRI report which is nearly benign, they have not even given the parent score there. They have said it to be practically benign. Then Soliraj, don't talk of biopsy. And also,
Yes.
if you notice there, they have done a very good MRI and they have said PSA density of 0.12. Suppose this PSA density was more than 0.15, then maybe you had some case ki, okay, the PSA density is high, I want to recheck that. But with a PSA density of 0.12, clinically benign in a 77-year-old man with a recurrent prostate, 160 gram gland, MRI showing benign, there is no place for biopsy at this time.
Because if you say biopsy, you will put your foot into it. And all the, like, all these things will do. So fine. So in this case, biopsy was not done. So Soliraj, what you will like to do? The
Sir,
medical management has failed. Patient has come to you. He is not very happy. He is, quality of life is affected. What you want to do?
Simple open prostate.
prostate is very big. We can go for bipolar TRP, sir.
Bipolar. So Soliraj wants to do bipolar. Hussein, what you want to do?
I want to prefer anatomical enucleation of prostate using whole gland laser, sir.
So you want to do whole. Fine. Ekant is there. What Ekant will like to do?
Simple open prostatectomy.
Which one? Prayers or milling or young?
Millions, sir.
Milling prostatectomy. Okay. So why you want to do milling prostatectomy?
So it's a huge gland, 160 cc gland, and
No, you are right. Milling prostatectomy, I love. I like to do milling prostatectomy. And most of the people are not doing milling prostatectomy because if you are not trained into that, it becomes little difficult because it is laparoscopy. It is you are not opening the bladder. Okay.
yes, sir.
And it is you can see under vision you are doing the prostatectomy. Right?
Yes.
So you can see it, you can detect it properly. The chances of incontinence are very less compared to prayer, and the bleeding can be controlled very easily.
Yes, sir.
So bleeding is definitely better than prayer.
Yes, sir.
And if there is any pathology in the bladder, like a stone or something, then better to do prayer.
Yes. Yes, sir.
Okay.
Yes.
Suppose if you are doing robotic, which one you will prefer?
Mm. Open only. Yes, sir.
No, I'm just telling you. I'm giving you that you are patient says that I want only robotic. Then you will prefer millings or you will prefer prayer.
No, still I'll prefer millions only, sir.
No, then in that case, millings becomes little difficult.
Okay, sir.
If prayer is much easier.
So, Ekansh,
If you are doing
I don't think there are any reports of robotic millings.
Okay.
See, and if I try to imagine it, it looks very difficult to do a retropubic dissection between the capsule and the adenoma, even with robotic system. So if
Yes.
you want to do robotic, it is always transfer cycle.
So always say that. Okay. Fine. So Solera, do you want to do this thing? Correct?
No, Solaraj wanted bipolar.
Acha, he wanted bipolar. Solera, why you wanted bipolar?
Sir, as the gland is very large, the chance of TR syndrome is high. So to decrease the chance of TR syndrome, I prefer bipolar.
So if you are well versed with all the procedures, you can do bipolar, you can do monopolar, you can do uh, Holder, you can do Sulet, and you can do open surgery. Which one you will select?
If I am confident, I will go for a whole up, sir.
Okay. Then why can't you call someone who is very good at Holder like our friend Maheshwari ji and get it done?
Yes, sir, I can.
Hmm?
I'll
So
send
you
you my
can
visiting
go.
card the moment you clear your exam.
No, so you can always say that, sir, in our then you have to say that, sir, in this case, Holder will be an ideal case, but we don't have, and I don't have experience. If needed, I will call someone. Otherwise, the second preference is to do bike. Or you can say open.
So again,
See, what
Solaraj
you
by
do actually is different than what you answer in exam. In exam, you have to answer what is right for this patient and what is given in the book.
So,
Yes, sir.
Solaraj, I feel the most difficult option to defend for this patient is going to be bipolar TRP. It will be safer to talk about open, it will be safer to talk about AEP, but not bipolar TRP, because even for the very experienced resectionist, 160 gram is on the higher side. Means
Correct.
then you would come up with risk of two-stage procedure, risk of bleeding, needing blood transfusion, and many other things, fluid intravasation. If not TRP, at least there is likely to be significant fluid intravasation. So among the options, I would not even consider bipolar TRP here. In exam, talk of either open or talk of AEP. Talk
Yes.
of HOLEP or anatomic and endoscopic enucleation only if you have been exposed to it in your training program. If your center does it, you know how things happen. Then talk of AEP. Otherwise, talk of open prostatectomy.
Yes, sir.
And again, there, if they say, is anything not possible, to say yes, we can do HOLEP, we can do robotic, but sir, I don't have any experience in this. So you again bring back the patient examiner to open prostatectomy.
Okay, sir.
So in this, Amit, what you will answer now?
So this patient, I would offer the patient the open simple prostatectomy or the laparoscopic simple prostatectomy. Uh, and apart from that, the laser enucleation, which can be done either with the holmium or thorium.
So the first choice will be, because you don't say nowadays we don't like to do open because the morbidity is always more. So what you will do is say if the facilities are available, I will like to do first. And the second choice is to do the open surgery. And if the examiner asks you anything else, then you can say in the experience say this procedure in a stage procedure or in a two sitting we can do it. But we must explain this all the complication and conflict to the patient. ओके गीते सर आपको कुछ ऐड करना है
I think गीते सर निकल गए शायद सर.
निकल गए. So we had kept this case because in exam you will get such a large prostate and that is why because we are regularly doing QRP or bipolar, then you will get carried out. So in exam, this platform is for you people how to answer in exam. In practice, what you do may not match exactly what you are going to answer me. Sometimes we may deviate. So this is the right answer. Please remember it. Okay? Fine.
Yes.
जैसे क्या किया था हम लोग ने कि नहीं किया है बाकी है
They are done TURBs.
ठीक है ओके फाइन ये नंबर जैसे फोटो में ओके so just to Maheshwari, one of our students has done this is this is on that time taken is more than 2 hours and the prostate size more than 80 grams and what are the risk of complications and other things. And we have found out like 3-4 of us have operated in many cases the chances of complication and redo surgery comparatively are very low. We are going to present that later on. But
Sure, sir.
of course, in the exam, we are not going to say this in the exam, laser or open.
Absolutely, sir.
Right?
Thank
Any
you, sir.
questions from students?
Thank you.
Okay.
Yes.
Oh. Good night to all
Good
of
night,
you.
sir. Thank you.
Thank you, sir.